Hi, my name is Corey Green. I'm a nurse practitioner student at Youngstown State University. Apologize for my voice. I'm getting over a cold and I'm pretty hoarse. I'm here with Kathy. Kathy, if you can just tell me like your name and your title.
My name is Kathy Lee Oles. I am a nurse practitioner. I work for the Cleveland Clinic. I have my master's degree from Malone University in Canton, Ohio, and I graduated in 2009.
Good. Can you tell me a little bit more about yourself?
Yeah, so after I graduated from Malone, I worked at a primary care office here in town. I was there for about 3 years, and I worked with another nurse practitioner who also graduated from Malone with me at the same time, so that was very nice, so we could bounce things off of each other. We had 4 physicians in that office, and two specifically for pediatrics, and then the other 2 for family practice. So we got a ton of experience with elderly, well visits, just minor sick visits, newborns all the way to in the 90s. Then I left there, and I have been at the Cleveland Clinic urgent care for about 8 years now going on, where again your basic urgent care visits anywhere from sore throat, sinus infection, to broken bones, some lacerations, things like that.
It's a good experience. Mm-hmm. Nice broad range of things.
Yes, and I like that, so yeah.
Okay. Can you describe your advanced practice nurse position and including your specialty? I know you kind of already touched base on it. But.
Right, yeah. So again, I am a family nurse practitioner, again from Malone, and I personally think that that's a good way to go versus adult or just plain pediatrics, because then you have a good range you can do. You're not limited to what you can do. Sorry, what was that? The current position.
Yeah.
Okay. So again, I family practice, and then currently I am doing the urgent care, where again we do a lot of the same things we would do in family practice with sick visits, urgent visits. We do get people who come in who we seem to be their family practice provider because they do not have one for one reason or another, and we don't love to, but we will do like some blood pressure and medication refills if they need it, if they've just moved here, or for whatever reason that they're out. Obviously we don't want them running out.
Yeah.
We do have some guidelines on that. We don't refill anything that is controlled. Obviously you shouldn't be running out of that. But we do try to help people in the community that way too, so they're not they don't have to go to the emergency department for something like that when it's really not an emergency. Try to keep them out of there too, but a good variety there. Anything from your patient coming in who's having a MI or stroke, or to just a runny nose and stuffy nose, but yeah, I really do like it there. So.
Awesome. What kind of hours do you work?
So we are open 8 to 8, Monday through Friday, and then 8 to 4 on the weekends. But I never plan to leave at 8, so it's that's
so you work full 12-hour shifts there?
Yes, most of the time I do 2 12s and an 8 right now. And then I do some work at home sometimes, like with just answering some office visits, like questions that come into the office sometimes when some other providers are out. We're closely linked up with the primary care offices for our urgent care. They're called UPS, Union Physician Services. So we're kind of under one big umbrella. We're in kind of the same building, so we get along well with them. We're very close. We see them every day, obviously, and we see a lot of their patients. So that union physician group, those patients who belong to those physicians, if they can't see them in the office, they want to funnel them into first care, so they're not being seen anywhere else. So we that's when I say we see a lot of the same patients. We know their physicians, some of their physicians are literally in the building next to us. So if they do come in and it's something a little more than, runny stuffy nose, maybe an elderly patient, oh hey, they had a blood pressure medicine change here a couple days ago, and now we've got some leg swelling, we're short of breath. Like it's nice because we can literally run across the building and just kind of grab them and be like, hey, this is what's going on. This is what I think, and are you agreeable? So that is kind of nice. So we do see a lot of those same patients. So sometimes we will help out with if they're out of town, or just helping with some of their messages and things like that.
Well, that's nice.
Yeah, so it's a good variety. And actually I'm going, we also have Workwell right there.
Mm-hmm.
So I'm going in a day or two down to do some bus driver physicals. They're called T8 physicals. And I also do Workwell, like DOT physicals, so I'm certified to do that. So that's nice. So again, I'm going out to the community to do something, obviously still through Cleveland Clinic and Workwell, but just something different,
Break it up a little bit.
Yeah. Actually, I think I have like 30
Wow.
to do. Yeah. So as long as everybody's healthy, we're all good. But and those are kind of cut and dry. They're very there's certain restrictions. There's guidelines. They have to follow all these and fall between these guidelines. So that is, I get to do that too. So that's nice.
Very nice. Do you see advanced practice registered nurses as an influence in today's healthcare system? And if so, how? And if not, why?
I definitely see a big influence of nurse practitioners in the healthcare system now, for the sheer number of them. And again, when I said, we see a lot of the same patients back at urgent care because they either don't have a family practice doctor or they just like us. Because, we hear this all the time. Oh, I can't get in to see somebody. I can't get into a doctor. I can't get into a doctor. And there have been a lot of physicians just leaving the area. We're hardly in a rural area, but there have been a ton of them. Unfortunately, when bigger companies like Cleveland Clinic come in and buy these practices up, some of those physicians just don't want to be an employee of a hospital. They still want to run their own practice, but they're having trouble doing that because of reimbursement even for them. So they, unfortunately, then they leave the area to go work somewhere else that is still in a private office, or they take their own office and take it somewhere else. So we have, I think APRNs are definitely filling a void for that, for sure. I mean, I do know a couple nurse practitioners who are in a more rural area who have their own clinics. They do everything, from, just your primary care practice up to some Botox and weight loss. They're really branching out and doing a lot of things. So I definitely think they are influencing. They have a good influence on healthcare and, again, meeting the needs here. So, yeah.
Great. What are some of the barriers that advanced practice registered nurses face?
I think sometimes some physicians still don't really like the role that the APRN plays, and then you will have the exact opposite. Like, you find some who are just like, I think kind of almost give APRNs a bad review, to some patients sometimes, where I feel that's absolutely not true. And then you have the exact opposite with some physicians who praise us and think we're the best thing. So I think that still is happening. That's a barrier for sure, but I know my own practice. Like, if I know what I don't know, so I can't say that I would feel comfortable running my own show all by myself. But there are other nurse practitioners who are great at that, and that is what they excel at, and they can do that. So I think sometimes we limit ourselves, and that could be a barrier, but some physicians being a barrier as well. Personally, the Cleveland Clinic doesn't seem to, they want you to work to your scope of practice. I have never felt where they're like, you absolutely cannot do that.
So they're more encouraging.
Yes, I truly believe that. I think I'm kind of insulated from some of the other barriers that people have in primary care, because we have a set of guidelines. You know, this is what we do at our urgent care. We don't do above that. We definitely work to our scope of practice there. We are not having like those reimbursement issues where some people in private practice or who own their own clinic would have, you know, with some orders even that still go through for home care and things like that. I think that some of those things did change when COVID happened and they just needed, you know, more people to be available. But again, they are out there. I can't, it's hard for me to speak to that because I can't say anything specifically, but I know they are still out there, but I am kind of insulated just with that. You know, this is what I am doing. I don't really think that I have one thing that I could say, oh, I wish I could do this and I can't do it. I don't think that's in my repertoire right now, that I would think that's a problem, so.
Well, that's good. It's good that they let you practice to your
Oh,
full
absolutely. Yeah, and prescribing, you know, we prescribe up to, you know, what we can do. And again, we don't prescribe controlled substances out of our facility. Once in a while we do, you know, narcotic or pain medicine if, you know, a broken bone, broken leg, you know, something very, it has to be, you know, pretty
justifiable.
Yes, for us to do that. But otherwise, yeah, I don't think I'm limited.
My last question is, what changes would you like to see for APRNs?
I do, I think like the collaborating agreement, I don't have any trouble with my collaborating physician, and I just think that might be a little antiquated. I'm not even sure why we need that anymore. If we are employed, you know, at a facility, you know, such as the Cleveland Clinic, you know, we are again working to our prescriptive authority and we are working within our scope of practice. I'm not sure why, you know, we do have a collaborator there. I can always call mine. I don't see him all the time. He is definitely not in my building. And at this point in my career, I don't really need him. You know, I don't have many questions that I can't bounce off one of the other APRNs that are at our facility. You know, again, that's good and bad. You know, I do see the same thing a lot of the time. And I'm very thankful that I had 3 years of family practice before I went to urgent care, just to have a really good basis, because you do see so many things in family practice. Or then you come to the urgent care and somebody might be coming in and saying, oh, you know, I think I have this, and I'm like, oh no, I think you have this going on, and it's something much more. So I think that's good. And again, I know what I don't know, so if I ever had a question, I would definitely follow up. And you know, he's very nice, and but I think maybe changing that, but again, you need to have physicians who are willing to work with you. Like if there is no collaborating agreement, you know, you still need to have physicians out there, you know, somebody who knows more than you do. There's always going to be somebody who knows more than you do. And again, there are some APRNs out there who have a greater knowledge base than I do because of what they've done and what they've seen in the practice that they're in. But with that being said, you know, maybe changing the collaborating physician agreement or getting rid of that altogether, having reimbursement be more, you know, if an APRN is providing the same exact care as an RN, or as an MD, sorry, that they should be getting reimbursed at the same rate. You know, there is absolutely no reason we should make 85% and they should make 100% of the reimbursement. Absolutely not. No, especially because, again, my personal point of view, you know, and you will talk to patients that a lot of the APRNs are spending so much more time, which is a big problem of mine because, you know, but I know these people. Like you know, I talk to them. You know, I have a hard time just being like, okay, you're here for a sore throat. Let me look at your throat. Okay, that's great. Let's go. I can't do that. So again, you know, when we're spending as much time or more time with the patient, I think the reimbursement rate should definitely be changed for that. With prescriptive authority, again, I am prescribing to my, what I feel I need. But I think if you are running your own clinic, if you are working in a rural community where you are providing all the care, then they need to have everything available to them and being reimbursed for that, for the job that they're doing, which would be no different than an MD. So, yeah. And again, you have to have those individuals who know what they don't know, mm-hmm. and not abuse that, because then, some people will, go the other way. But, I would hope that wouldn't happen, but
maybe that's one of the reasons that they've been hesitant thus far.
Right, true.
Unfortunately, but
right, because, then you always have these people, oh, I know I can do this,
mm-hmm.
or, that's always been, I taught for, Stark State on the RN program. I did some graduate work from Malone, but I always thought the students who thought they knew everything right away were the most concerning. Yeah. So, but I think that those are the things that could change and be beneficial, definitely in certain areas. So,
good. Yeah. Well, thank you so much for your time today.
You're welcome.